Welcome to Med Madness, the podcast where we dive deep into the fascinating world of medicine. I'm your host, and today we're exploring the intriguing topic of fetal malpresentation. We'll discuss transverse lie and breech presentation, their dynamics throughout gestation, and how they are managed. Stay tuned as we unravel these critical aspects of obstetrics and share a real-life case study at the end. Let's start by understanding transverse lie. This condition occurs when the fetal spine is perpendicular to the long axis of the uterus, resulting in a shoulder presentation, where the shoulder is the fetal part closest to the cervix. In early gestation, this is quite common. At this stage, the fetus is small and has ample room to move around within the uterus, frequently changing positions. As a result, abnormal fetal lies and malpresentations like shoulder or breech presentations are not unusual. However, as gestation progresses, things begin to change. With increasing gestational age, the fetus grows larger and the relative volume of amniotic fluid decreases. This combination leads to reduced fetal mobility. By term, which is considered to be 37 weeks of gestation or more, the majority of fetuses have spontaneously rotated into a longitudinal lie. This means the fetal spine aligns parallel to the long axis of the uterus, preparing the fetus for delivery in the most effective manner. Cephalic presentation, where the head is the presenting part. For patients presenting with a transverse lie at preterm gestations, the management is usually expectant. This means we monitor and wait, as most fetuses will rotate on their own by term. An ultrasound is typically performed at term to evaluate the fetal presentation. When it comes to managing malpresentation at term, one option is an external cephalic version, or ECV. This procedure involves manually rotating the fetus to achieve a cephalic presentation. ECV is typically performed at 37 weeks or later because attempting it earlier is unnecessary due to the high likelihood of spontaneous rotation. Additionally, ECV carries risks such as pre-labor rupture of membranes and abruptio placentae, which can necessitate immediate delivery and pose complications, especially if performed before 37 weeks. Importantly, ECV is not recommended during active labor due to its low success rate at that time. Next, let's shift our focus to breech presentation. Breech presentation occurs when the buttocks or feet are the fetal parts closest to the maternal cervix. It's a common type of fetal malpresentation and carries an increased risk of complications during vaginal delivery, including delivery trauma, umbilical cord prolapse, and head entrapment. There are different types of breech presentations. In a frank breech, the hips are flexed and the knees extended with the buttocks presenting. A complete breech involves both hips and knees being flexed. In an incomplete breech, one or both hips are not flexed, resulting in the feet presenting. Breech presentation can be influenced by several risk factors such as advanced maternal age, uterine abnormalities like didelphys or septate uterus, uterine leiomyomas, fetal anomalies like anencephaly, preterm gestation, oligohydramnios or polyhydramnios, and placenta previa. Managing breech presentation often involves offering an ECV at 37 weeks or later, provided there are no contraindications to vaginal delivery, such as placenta previa or a prior classical Cesarean delivery. If ECV is unsuccessful or not feasible, a Cesarean delivery may be necessary to ensure the safety of both the mother and the baby. To illustrate these points, let's discuss a real-life case study. Imagine a 34-year-old woman at 36 weeks of gestation who presents with a transverse lie. An ultrasound confirms the fetal spine is perpendicular to the long axis of the uterus. Given her preterm status, her obstetrician decides on expectant management, planning for a follow-up ultrasound at 37 weeks. By the next visit, the ultrasound shows that the fetus has rotated into a longitudinal lie with cephalic presentation ready for delivery. This case highlights the importance of monitoring and the natural tendency for fetuses to assume the optimal position by term. Thank you for joining us on this episode of Med Madness. We hope this discussion on fetal malpresentation has provided you with valuable insights. Stay tuned for more episodes as we continue to explore the fascinating world of medicine. Don't forget to share your thoughts and experiences with us. Until next time, take care and keep learning, and that's a wrap for today's episode. If you enjoyed this deep dive into fetal malpresentation, be sure to subscribe and leave us a review. Your feedback helps us bring you more content that matters. Have a topic you'd like us to cover? Let us know. See you next time on Med Madness.